The recent issue of the Indian Pediatrics, that is February 2022, has given the revised IAP 2021 guidelines on vitamin D deficiency and rickets. I have made a video on this for a better understanding and wider circulation. So before moving on to the guidelines per se, let us revise our knowledge about the metabolism of vitamin D. Vitamin D is synthesized in the skin from 7-dehydrocholesterol under the presence of ultraviolet B rays from the sunlight, and it forms vitamin D3 or cholecalciferol. In plants, the steroid ergosterol forms the vitamin D2, which is referred to as ergocalciferol. Vitamin D can also be taken from extraneous sources. It then metabolizes in the liver in the presence of enzyme 25-hydroxylase and undergoes hydroxylation at the 25th position to form calcidiol, and then it gets metabolized in the kidney. At the first position, it undergoes second hydroxylation to form calcitriol or 1,25-dihydroxycholecalciferol. So we see that 25-hydroxy-D or calcidiol is the major circulating form present in the blood. Therefore, whenever we want to estimate the levels of vitamin D in blood, we estimate the levels of 25-hydroxy-D. We also see that 1,25-dihydroxycholecalciferol. This is the active form of vitamin D, and it is the major hormonal form which is responsible for the actions of vitamin D. So, vitamin D 1,25-dihydroxycholecalciferol or calcitriol is responsible for action, whereas calcidiol is meant for estimation of vitamin D. So these guidelines define or classify the vitamin D status in a child, and it is said that the status should be defined on the basis of the levels of 25-hydroxy-D in the serum. So a child can be deficient if the levels are less than 12 nanogram per ml. He is insufficient in vitamin D if the levels are between 12 to 20 nanogram per ml, and is sufficient if the levels are more than 20 nanogram per ml. Now there are certain investigations which you might like to perform in patients with hypervitaminosis. So what is hypervitaminosis or vitamin D toxicity? It is 25-hydroxy-D levels more than 100 nanogram per ml with hypercalcemia and or hypercalciuria. But you must remember that levels of 25-hydroxy-D between 50 to 100 nanogram per ml should raise a caution. So levels less than 12 are deficient, 12 to 20 is insufficient, 20 to 50 is sufficient, 50 to 100 be alert or cautioned, and more than 100 is hypervitaminosis. If it is accompanied with hypercalcemia or hypercalciuria, then it is vitamin D toxicity. Serum parathormone levels will be suppressed in cases with vitamin D toxicity, and 24-hour urinary calcium excretion will be more than 4 mg per kg per day in these patients. You must also remember the upper limit normal for serum calcium from birth to 12 months is 11.3 mg per deciliter, from 1 to 3 years it is 11.1 mg per deciliter, and from 4 to 18 years it is 10.7 mg per deciliter. Also, the normal urine spot to calcium to creatinine ratios up to 6 months of age is less than 0.8, 6 to 12 months of age is less than 0.6, and from 12 to 24 months of age it is less than 0.2. Why do we take spot calcium creatinine ratio? Because if there is any variation in the creatinine excretion because of any kind of renal dysfunction, calcium will be also altered accordingly. So the ratio will be more beneficial rather than taking the value of urine calcium per se. So the prevalence data for vitamin D deficiency, the national data is not available for infants, but the data as per some hospital and community based studies says that vitamin D deficiency is prevalent in infancy from up to 22 to 92%, and in older children and adolescents it ranges between 14 to 24%. For estimation of vitamin D levels, I have already told you people that 25-hydroxy-D levels should be done, and they are best measured with liquid chromatography coupled with to ultraviolet or tandem mass spectrometry, and in case this facility is not available at a center, then in that case automated immune assay may be used. Now see, the maternal vitamin D status has been found to have no effect on the anthropometry or the bone density of the neonate or the child, but it can result in a biochemical vitamin D deficiency. That is, if the mother is deficient in vitamin D and we assess the vitamin D status of the newborn, that is, we test the serum 25 hydroxy D levels in them, then the child might be found to be deficient in that. The child can also be suffering from neonatal hypocalcemia if the deficiency of vitamin D is severe in mother. Otherwise, it has no effect on the anthropometry and bone density per se. And vitamin D supplementation may improve the biochemical vitamin D deficiency in these children. But you must remember that therefore vitamin D is not universally recommended during pregnancy. It is not recommended during pregnancy. And routine calcium supplementation, however, should be ensured to optimize maternal and neonatal health outcomes. As regards infants and children, routine vitamin D supplementation is recommended in infancy. As we all know, the dose is 400 IU per day, and even this is meant even for preterm babies, and this has also been stressed upon by these guidelines. Higher doses such as 1600 international units per day can result in toxicity. Routine vitamin D supplementation is also recommended in children with underlying high risk conditions. So there are two basic indications for routine vitamin D supplementation. First is infancy, including preterm babies, and second is certain high risk conditions. So what are these high risk conditions? First is the non-ambulatory states like patients with neurological disorders like cerebral palsy, neuromuscular disorders, chronic kidney disease, chronic liver disease, as we know that vitamin D metabolism occurs in liver and kidneys, malabsorption syndromes, drugs, especially long-term steroids like glucocorticoids, also anti-epileptic drugs and ketoconazole, endocrine disorders like hyperparathyroidism, and disorders with extensive cutaneous involvement. Also, routine vitamin D supplementation is not recommended during childhood and adolescence. And routine screening of healthy children is also not recommended. So, the estimated average requirement in these children, which is around 400 to 600 international units, should be met with by exposing the children to sunlight and from dietary sources. So, routine supplementation has not to be done, but you must expose these children to sun and provide them vitamin D rich diet. So, guidelines for sunlight exposure say that a daily sunlight exposure of around 17 to 30 minutes in infants and 30 to 45 minutes in older children over 15 to 40% of body surface area is recommended at least 5 times a week, and the time recommended is between 11 a.m. to 3 p.m. Daily application of sunscreen is not recommended for routine use in children, which obviously in India people are not doing, especially most of the people are not doing. And the risk of skin cancers with prolonged sunlight exposure is yet not known in the Indian pediatric population. As regards diet, an adequate intake of calcium should be ensured during the entire childhood, and foods rich in vitamin D may not alone be sufficient to meet the vitamin D requirements, but their intake should be encouraged, because we know that the major source of vitamin D for children and adolescents is sunlight exposure. But a diet deficient in vitamin D can have adverse effects. So, as already discussed, indications for treatment are primarily three. First is children with nutritional rickets. They should be treated and monitored for therapeutic response. Second is children with other symptoms attributable to vitamin D deficiency like hypocalcemic seizures, tetany, dilated cardiomyopathy, and having serum 25 hydroxy D levels less than 20 nanogram per ml. That is, even if the children are not deficient, they are only insufficient, but they have symptoms. That is the vitamin D deficiency symptomatic. Then also you need to treat them. And finally, even if you detect low serum 25 hydroxy D levels incidentally, low means deficiency state, that is less than 12 nanogram per ml, even in healthy children, or less than 20 nanogram per ml in those at high risk, like the high risk conditions I've already discussed previously. In these children also, you need to give vitamin D supplementation for treatment. For treatment, daily treatment doses are recommended as the first line of management. And why? Because intermittent bolus dose safety is not established, especially in infancy. Like initially, we used to give 6 lakhs IU intramuscularly. We should not routinely follow it, whenever we are giving therapeutic doses or treatment doses, we must recommend daily treatment doses. So, in less than 6 months of age, the daily dose is around 2000 international units per day, and intermittent dosing is not recommended. Once the deficiency is over, then you start with maintenance doses of 400 IU per day. Between 6 to 12 months also, the daily dose is 2000 international units per day, and equivalent dose may be given on a weekly or monthly basis but should preferably be avoided because intermittent bolus doses safety has not been established. And again, the maintenance dose needs to be started once the deficiency is over. In more than 12 months, however, the daily dose is 3000 international units per day, and alternatively you can give 60,000 international units every 2 weeks for approximately 5 doses, that is around 3.5 months. And the maintenance dose in these children is 600 international units per day to be given after the deficiency has been made over. You must also continue this therapy of daily dosing for approximately 12 weeks and assess the response after 12 weeks. Per oral calcium in the dose of 50 to 75 mg per kg per day should be supplemented along with vitamin D, and the dose of calcium should not exceed more than 500 mg per day in children and infants. The optimum duration of maintenance therapy, however, is not known. We are talking about the maintenance therapy. 12 weeks is the duration for the therapeutic treatment, therapeutic doses. Now, there are different formulations of vitamin D. So, oral treatment is recommended, as we have already seen. Daily dosing is recommended, oral treatment is recommended because oral treatment has been found to restore 25 hydroxy D levels faster and is safer. Obviously, parenteral route say better hai oral route. Then the other thing is that these guidelines suggest that intramuscular route should be used only when there are issues of absorption of the oral dose, for example in malabsorptive states. So when intermittent bolus doses are used in infants, in children more than 1 year of age, then vitamin D3 is more efficacious than D2 in improving the vitamin D status. That is, the animal sources is more useful. And for daily treatment, vitamin D3 is only marginally better than D2 in improving vitamin D status. Also, alpha calcidiol and calcitriol are not recommended for the management of nutritional rickets and vitamin D. So, if you are confused between different terms, let us revise. Vitamin D, which is formed in the skin, is referred to as cholecalciferol, and it is the inactive form. Vitamin D2 is that which is obtained from plants. It is referred to as ergocalciferol. And the preparations of vitamin D, that is vitamin D3, mainly comprise of alpha calcidiol, which is 25 hydroxycholecalciferol, calcitriol, which is 125 dihydroxycholecalciferol, and cholecalciferol, which is the inactive form which we have seen earlier in the skin. The guidelines also say that the healthcare providers should be well abreast of various vitamin D preparations available in India, and they should be able to counsel patients regarding both the desirable doses and the variability among formulations. So I was searching the internet about various formulations of vitamin D which are there available in India for the pediatric age group. I was not able to find it clearly, but I have been able to find the study by Lamo Y et al., and it has been published in Indian Journal of Pharmaceutical Sciences in the year 2016, and it has shown the various preparations which are available in the Indian market about vitamin D, and these are obviously in adults. As you will see that most of the preparations, they are containing either calcitriol, that is 125 dihydroxycholecalciferol, or alpha calcidiol, that is 25 hydroxycholecalciferol. Hardly one or two they are having cholecalciferol, and ergocalciferol is still not available. Rather, they say that they had studied around 258 medications available in India in the year 2016 I'm talking, and only two of these preparations had ergocalciferol. Now coming on to the monitoring during treatment. So radiographs should be obtained at 4 weeks and 12 weeks after giving vitamin D therapy in children to look for the evidence of healing, and biochemical tests should be performed at the end of 12 weeks of vitamin D therapy. I have earlier told you people that vitamin D in therapeutic doses should be continued for at least approximately 12 weeks. So after the end of 12 weeks, you must perform the biochemical tests like serum calcium, phosphate, serum alkaline phosphatase, and serum 25-hydroxy D levels, along with the radiograph. But a radiograph should also be done at 4 weeks, that is after 1 month of therapy. If complete radiological healing and normalization of biochemical parameters is not attained by 12 weeks, the therapeutic doses of vitamin D and calcium should be continued, and maintenance doses should be started only once complete healing has been achieved. Urine calcium to creatinine ratio and renal ultrasonogram should also be done whenever there is hypercalcemia or hypervitaminosis or vitamin D toxicity. Because you want to rule out vitamin D toxicity, you need to perform these tests. Now, the role of vitamin D has also been studied in some infectious conditions which the IAP has explicitly mentioned in its guidelines. In pneumonia, it has been seen that low vitamin D levels are associated with increased incidence and increased severity of pneumonia. But routine supplementation of vitamin D is still not recommended in patients with pneumonia. Also, low levels of vitamin D are found in patients with tuberculosis, but routine supplementation is not recommended. An association is also seen between vitamin D deficiency and HIV, but the therapeutic effect is not yet established, and in acute diarrhea, the vitamin D levels correlate poorly, and routine supplementation is still not recommended. So, coming on to non-infectious states like these conditions which have been mentioned by the guidelines. In asthma, it may be as vitamin D deficiency may be associated with reduced lung function and asthma exacerbation, but the benefit of routine supplementation of vitamin D in asthmatic patients is still not proven. In obesity, the vitamin D status is associated with obesity and glycemic handling, but the dosing amount and frequency of vitamin D cannot be generalized to these obese patients. In atopic dermatitis, it is associated with pathophysiology, but still the routine supplementation is not recommended. With nephrotic syndrome is a known cause of vitamin D deficiency, and supplementation in these patients is recommended. So this is important. Even in patients with attention deficit hyperactivity disorder and autistic spectrum disorder, vitamin D deficiency is associated with higher incidence of these illnesses, and in these patients the routine supplementation, nothing has been said about routine supplementation, but what has been said is that optimal levels need to be maintained. Now, coming on to investigations, you can call nutritional vitamin D deficiency as a primary vitamin D deficiency and non-nutritional rickets as a secondary kind of rickets. Some another pathophysiology is involved. So the investigations which you need to do in every case of rickets, especially the nutritional rickets, the treatment of which is simple, is serum 25-hydroxy D levels, as has been stressed upon several times in the video, serum calcium, serum phosphate, serum alkaline phosphatase, and X-ray wrist and knee. But if you suspect if there is a non-nutritional cause, then you also need to perform liver function test, renal function test, serum parathormone, serum bicarbonate levels, urine calcium creatinine ratio, USG abdomen to rule out nephrocalcinosis, and you must also rule out Fanconi syndrome, for which you perform urine bicarbonate, phosphate, glucose, amino acids, and uric acid in the urine, along with serum bicarbonate levels. So, coming on to the summary of some important recommendations, the guidelines have defined and have classified the vitamin D status, and we know that this should be based on the levels of 25-hydroxy D levels. Routine supplementation is primarily recommended in two conditions, that is the infancy, including preterm, and the high risk conditions, for example, nephrotic syndrome in patients on long-term antiepileptic drugs and glucocorticoids. And otherwise, only therapeutic supplementation is to be given in doses of 2000 international units per day in infancy and 3000 international units per day in children who are more than 1 year of age. Also, the preferred dosing route is oral compared with intramuscular, because intramuscular route needs to be given only when there are issues with absorption of the oral drug. The preferred dosing regimen is daily along compared with intermittent dosing regimen, and a follow-up must be done at 12 weeks to look for normalization of biochemical parameters, and a repeat X-ray should be performed at the end of 4 weeks and at the end of 12 weeks of therapy for determining the radiological healing. And only then, when healing is complete, only then should you start the maintenance doses. Otherwise, you must continue with the therapeutic phase. Thank you so much for a patient watching and listening. And please do share the knowledge for a wider coverage and better understanding. Thank you.